Thank you so much, sir. So after the fascinating talk by Dr. Deepak, it's my job to how we can help patients with pharmacotherapy so that they can sustain all the different diet plans which we discussed just back. A big thanks to the organizers and the scientific committee for making me a part of this beautiful conference. So yes, moving on from where exactly Dr. Deepak left, I would just directly show a paper published nearly 7 to 8 years back in Lancet, which talks about how Indians are dying, how we all die. So this is a map of India showing different shades of red. Greater the red color means greater the death because of communicable disease. So this is 1990, just before economic liberalization. So the darkest red means for a single death by communicable disease, there were non-communicable disease, there were 1.7 times the death because of communicable diseases. So for a country with a written history of more than 5,000 years, something staggeringly happened over 26 years. In just 26 years, the entire country has changed to different shades of blue. Only Kerala was blue in 1990. Now the entire country is blue in 2016. Now for every death because of communicable disease, there are nearly double the number of deaths because of non-communicable disease, and cardiovascular events are the most common cause of death for Indians. You can combine road traffic accidents, you can combine cancers, you can combine all the possible cause of deaths together, there will be still less than cardiovascular events, and it is the problem of obesity. So this is the data from our clinic we published nearly 6 years back. We are very meticulous in recording the height and weight of all people. These are everybody, not only people with diabetes, anybody coming for routine checkup, just a consultation. If you see here, from 5,300 odd patients, normal BMI people are defined as BMI between 18 to 23.5. They are endangered species, at least in western part of Delhi. Only 13.7% were normal BMI. 68% were obese and morbidly obese. Forget the overweight also. So that is what we are, as Dr. Deepak highlighted. Obesity is taken as a norm. If a person is normal BMI, उसको लगता है बीमार तो नहीं हुई, कि टीबी की दवाई तो नहीं खा रहा, कोई बड़ी बीमारी होगी बेचारे को. So that's the understanding, at least in Delhi. And where we doing in them? So till around maybe 5 or 6 years back, we had metformin, been there for more than 70 years now. We had SGLT2 inhibitors for around last 10 to 15 years. And we had orlistat with us for nearly 25 years now. So we were trying to use them in different permutations and combinations. And in our cohort, we tried them together, maybe a bit of liraglutide also. We were able to cause maximum 7 kilos of weight loss. I know we advise a good low-calorie diet, but implementation becomes a challenge with most of us in the real-world scenario. So we were not doing great in terms of causing weight loss for our patients. This is the data from the CAR study, again coming from AIMS, which looked at the population-based prevalence of diabetes and prediabetes. So this is the population-based, not a hospital-based study. If you look at the data from Karachi, Chennai, and Delhi, in Delhi at least 47% of the people were having prediabetes, and another 25% were having type 2 diabetes. That is like 7 in 10 of people in Delhi are metabolically challenged. Even in this hall, many of us will be metabolically challenged. We just don't check ourselves. So we are sitting on the tip of iceberg, which will be apparent with cardiovascular events, end organ damages 5, 10, or 20 years down the lane. So much is the seriousness of the problem. And the only way we can do this by causing weight loss and by no other methods. Following what Dr. Deepak said, and these medicines are adjunctive so that we know losing weight is difficult, maintaining the weight loss is even more difficult. So that is, we are talking of changes over 5 to 10 years and not just over 2 to 3 months. So these were the medicines for weight loss which have been with us for the last 10 to 20 years. Orlistat, most popular but best tolerated, but causes the least amount of weight loss. Usually 2 to 3% is the weight loss it causes. Topiramate, phentermine, not available in the country. Naltrexone, bupropion, not available in the country. Both of them are recommended only for 6 to 8 weeks use, not beyond that, even in the US. We have lorcaserin, it was working great, but it causes a rise in BP, increased cardiovascular events. So the history of weight loss medications are pretty checkered. A lot of drugs came, they went off because of some unwanted side effects. Nothing stood the test of the time. Liraglutide has been there as a primarily as an anti-diabetes agent at the doses which is available in our country, which is 0.6 milligram to 1.8 milligrams daily injections. It can cause around 2 to 5% weight loss. The weight loss dose for anti-obesity dose for liraglutide, the daily injection is 3 milligrams per day, but that dose is not available. But of course, we can inject more. But the higher dose we use, the more the GI side effects we cause. So what are we trying to achieve when you are trying to lose weight? We should be very clear. So if a person, a lot of people, they see your Facebook, WhatsApp forward, they are talking of diabetes remission, but that's not easy to do. If somebody loses 2 to 3 kilos, diabetes remission is not happening. So if an obese person with diabetes, if they lose around 5 kilos weight, of course you can bring down the pill count, the total insulin dose may come down, they may even be able to even stop insulin also. But talking of remission at 5 kilo weight loss is not possible. The moment you cross from 5 to 10 kilo weight loss, you get some added benefit, which is reduction in metabolic dysfunction associated fatty liver disease, the current term for non-alcoholic fatty liver disease. Fatty liver is another big problem. 50 to 60% of our Indians are living with fatty liver disease and we don't even know. Most of them, the problem with USG is that it picks up fatty liver only when the liver fat content is more than 20%. MR spectroscopy and MRI considered to be a more sensitive tool to pick up fatty liver. It picks up fatty liver at more than 5%, but it's a much more costly test. We cannot replicate it in large scale in the population. So, and the most common cause of end-stage liver disease is obesity and diabetes in our society. Yes, you need to lose a greater amount of weight if you want to revert MASLD, if you want to improve PCOS, so common, hirsutism, acne is so common in young girls. You need a greater amount of weight loss, not just 5 kilo. The moment you cross more than 10 kilos, 10 to 15 kilos weight loss, you can reverse even sleep apnea. People who are on BiPAP, we can even get them rid of BiPAP. The GERD, the reflux improves. When we talk of remission of diabetes, which is defined as maintaining an HbA1c of less than 6.5 and no need for any medication for at least 3 months, you need to lose at least 15% or 15 kilo of your body weight. So that's a big thing to do. And the direct study showed us that as long as you maintained your loss of weight, you remain in remission. The moment you regain the weight, your diabetes, hypertension, everything comes back. So what happens with this amount with the total weight loss, we are able to lose that amount of hepatic fat and pancreatic fat. Now we know that each one of us has a critical threshold of hepatic fat content and pancreatic fat content determined by our genes, beyond which the liver stops responding to insulin and beyond which the pancreas starts reduction in the production of insulin. Once we are able to reduce that critical threshold of hepatic and pancreatic fat, the insulin secretion comes back, the beta cell recovers, and the hepatic response to insulin improves, and we have a remission of diabetes. That critical threshold हमारी तकदीर बताती है, जो genes हमें अपने माता पिता से मिली है. So why is it important for OA? For OA also, I think the greater amount of weight loss is needed to have a meaningful benefit in this patient. Yes, you can defer joint replacement surgeries. This paper published in 2022 in International Journal of Obesity showed evaluated data from 8,000 odd joints from 4,000 odd patients. It showed that for every 1% weight loss, you have a 2% reduction in need for knee replacement and nearly 3% reduction need for hip replacement. So the benefits are slightly more with regards to hip joint as compared to knee joints from this paper. Another paper published in the same journal, again, analyzing the data from national databases from Australia and US, showed that in a cohort of nearly 24,000 odd patients, nearly 8 to 9% who lost more than 7.5% of their body weight from baseline, and there were other groups who lost lesser amount of weight. If you lose 7.5% or more weight, you can really make a difference in deferring or totally avoiding the need for total knee replacement in people who are obese or overweight and living with osteoarthritis. Another study showing network meta-analysis showing that pain is a major feature. Patients come to us with pain. Again, the point here, if you see, you need a 25% reduction to really make a difference to make the patients pain-free. Again, showing that you need a greater quantum of weight loss to prevent the degenerative disease progression as compared to the metabolic benefits which we saw a few slides back. Again, this is the Chinese data looking at the use of GLP-1 receptor agonist, the molecule of the day in terms of causing weight loss. They have evaluated in their setting. They saw that people who continued GLP-1 receptor agonist and who lost at least 7.2 kilograms of body weight over a period of 5 to 6 years of follow-up in the real-world scenario, the need for knee surgery in people, those who lost weight, was only 1.7% as compared to nearly 6% in people who were not on GLP-1 analog-based weight loss treatment, showing that nearly 3 to 4 times the benefit weight loss does make a difference, there is no doubt. So let's talk of the newer molecules which are available, which are going to come in the next few years in our country. Liraglutide 3 milligrams, not available, but you can do jugaad and keep on building up the dose, can cause nearly 8% weight loss at 1 year. So key point is 1 year sustained weight loss. Semaglutide injectable is known to cause a greater amount of weight loss. Injectable semaglutide is not available in our country. We have only oral semaglutide that is slightly less efficacious in terms of weight loss than the injectable. The good thing is injectable semaglutide is going off patent by the end of this year. So next year we will be flooded with more affordable and generic once a week injectable semaglutide. The anti-diabetic dose is 0.5 to 1 milligrams weekly injections. The anti-obesity dose is 2.4 milligrams weekly injections. Amazing, 16% durable weight loss after 1 year of use. It's a GLP-1 agonist moving on to a dual gut peptide agonist. Now this is tirzepatide. Both of these molecules are a rage and is off the shelf in US and Europe. Tirzepatide is not only glucagon, GLP-1 receptor agonist, it's a GIP receptor agonist also. So it's a twin creatine. It inhibits 2 gut peptides. These peptides work by decreasing the gastric emptying. A food which stays in our stomach for at least 3 to 4 hours, once we take semaglutide or tirzepatide, is going to stay there for 6 to 7 hours. So we feel satiated. We don't feel like eating for the next 6 to 8 hours. Side effect, food stays in stomach long. They tend to come up with more reflux, more acidity, more of heartburn. And also nausea also. They have some direct central effects at the satiety center that also explains the increased occurrence of nausea and vomiting. And some of the patients also have loose motions also, and some have constipation. So varied presentation of the same medicine in different individuals. No pain, no gain. Greater the quantum of weight loss, greater will be the quantum of GI side effects. So all regimens say these are the therapeutic doses. We typically start at low dose. Tirzepatide at 10 to 15 milligrams per week causes this amount of weight loss. We are told to start at only 2.5 milligrams per week. Every 2 weeks we increase to 5 milligrams, 7.5. Stop where the patient is not able to tolerate. Step up and step down. It is going to vary from person to person. So it's very important to tell this patient the side effects, or they'll keep on cursing us. Doctor, आपने तो बताया नहीं इस दवाई से ये सब होने वाली है. So the point again is we showed that in lower dose of semaglutide at half the dose which is recommended for managing diabetes, that is also good enough to reverse a metabolic dysfunction associated fatty liver disease. If you look at the data of tirzepatide, the data is staggering. This systematic review of 6 RCTs of 3,500 odd patients showed that when you compare to full dose of semaglutide also, it causes an additional 8 kilograms of weight loss. So that's really, Sema was considered the gold standard till we had tirzepatide. This molecule from Eli Lilly is going to come into India in the first quarter of next year. So it will have more options. The patient will have more options to choose for themselves. And the anti-hyperglycemic benefits are very good. They are some of the most potent anti-diabetic agent. So the question comes, when we talk of obesity, a lot of obese people are not diabetic. What happens when we use them, these medications? Are they going to cause hypoglycemia? The answer is no, because they work on the incretin principle. So you need a particular level of blood glucose for the incretin to stimulate the insulin release from the pancreas. In a euglycemic patient, that blood glucose-driven insulin release will not happen, and hence when you use these medications in non-diabetic obese people, they will still have weight loss based on their central effects, the GI effects, but they will not have hypoglycemia. This systematic reviews showed that when tirzepatide was used in obese, non-diabetic individuals, they were able to lose weight 19.44%. That's huge. That we are talking of weight loss which is seen with sleeve gastrectomy now. Of course, with biliopancreatic diversion, and the next talk we'll talk of has the greatest amount of weight loss. At least now we have pharmacotherapy which can match up with sleeve gastrectomy in terms of causing the quantum of weight loss after 1 year of therapy. I would also like to highlight another set of gut peptide, which is the amylin-based therapies, the cagrilintide. Now we know that pancreas, every time it releases insulin, an equal amount of amylin comes. It's a short peptide, half-life of only few minutes. We had pramlintide for a long time, thrice daily injection, approved for use both in type 1 and type 2 diabetes, never caught up in our practice. But now we have cagrilintide, a very long half-life, again once a weekly injection. The USP of this peptide, it works as good as semaglutide with a fraction of nausea and vomiting, nearly 70 to 80 times lesser risk of nausea and vomiting when cagrilintide was used alone. Of course, we have a cagrilintide sema-fixed dose combination because they have the same half-lives. So in clinical trials, they showed that when you combine 2.4 milligrams of cagrilintide with 2.4 milligrams semaglutide, once a week injection, it caused an additional around 8 to 9% extra weight loss over sema. So now we are talking crossing 20% better, 20 to 23% weight loss from baseline. Again, the GI side effects are staggeringly higher with cagri-sema. So no pain, no gain. या तो खुद खाना बंद करो या दवाई बंद कराएगी. खाना देके भागना पड़ेगा. So that is the nutshell of all gut peptides based therapies, be it injections or be it tablets. This is the key outcome. I'm not going to detail, just to show that the percent weight reduction pretty much staggeringly high, and the GI side effects are also high. But with this weight loss, you need for diabetes medication goes away, you need for blood pressure medicines goes away, you need for fatty liver medicines also goes away in these settings. So then there's a new molecule again. So tirzepatide is brought by Eli Lilly, staggering outcomes with tirzepatide, but they still chose to develop this molecule, retatrutide, which is now a triple gut peptide agonist. You had the GLP-1 agonist, GIP-1 agonist, now add to it a glucagon receptor agonist. This in clinical trials, phase 3 trials showed around 24 to 23% weight loss from baseline. This molecule is still not approved for use in any part of the world. It's an advanced part of phase 3 trial. It will soon come. There is some reason why Eli Lilly chose to develop this molecule in spite of having a super hit molecule like tirzepatide doing so well across the globe. So much more is to come in this session, in this section. What remains here is that these are all injections, either daily or weekly injections, and we Indians are a prick-phobic society. Half the time we spend in our obesity to counsel the patient ki insulin shuru kar lo. We talked of insulin to patient, they said that we have given them a death certificate. So that's why being injectable is another barrier for our society. So now we have oral, non-peptide based weight loss therapies. So all the previous molecules were peptides. So we have gut endopeptidases. When we swallow them, our gut endopeptidases destroy the molecules. But this is a non-peptide molecule, orforglipron, daily tablets of different doses, 12, 24, 36 or 48 milligrams. They are also shown they are not as efficacious as tirzepatide or retatrutide, but they still cause around 8 to 10% of weight loss. We know we have good metabolic benefits with 8 to 10% of weight loss after 48 weeks, nearly almost a year of therapy. A lot of hue and cry with semaglutide. भी पहले आया था कि यार कैंसर हो जाता है, thyroid cancer, parathyroid cancer. We reviewed data of more than 50,000 published patients from clinical trials, and we saw that there is no increased risk of any cancer. Similarly, now it is coming in, the JAMA paper came just 2 weeks back, about 1 week back in fact, which showed that the occurrence of ischemic optic neuritis, so something they are calling it like the eye stroke is they reported, but that is an observational study of 19 odd patients from a cohort of 900 patients. That's a very high number, like nearly 8 to 9% of the patients from a tertiary care ophthalmology center. In all the clinical trials, there have been no report of any optic neuritis with the use of semaglutides. Of course, this has come, it will be looked into, nothing to panic. Another thing which came a few years back with GLP-1 agonist-based therapy like liraglutides and semaglutide, they were saying it can cause retinopathy or worsening of retinopathy. Then we know that all of these are potent anti-diabetic medications in any person with underlying non-proliferative retinopathy. If you rapidly lower the HbA1c using any medication, be it a GLP-1 analog or insulin, rapid reduction of HbA1c can worsen undiagnosed pre-existing retinopathy. So that warning is also gone. So of course, when we talk about new class of medicines, we always talk of the good things in the first 5 to 6 years. Then we always talk of the bad things in the next 5 to 6 years. Maybe after 10 years, we'll reach a plateau stage where we'll know all the good things and bad things together and how to use them in our practice. So the next session is about bariatric surgery. So medical management.
I'm sorry to interrupt you. Yeah, I think.
I think so. I'll wrap up by saying that bariatric surgery patients post-bariatric surgeries do very well on medical management of obesity. I would like to end by this slide. This is the future of gut peptide-based therapies, and we are going to have more and more molecules coming up. Thank you so much.